morning, everybody, and welcome to this month's vlogcast. I'm delighted to have Dr. Arvind Pillai from the Countess of Chester Hospital with me today. And Dr. Pillai is going to be talking about the use of interferon. Welcome, Arvind, and how nice it is to see you here. I might add to everybody that he's a great supporter of MPN Voice and has hosted forums in Chester for a number of years for us. Anyway, welcome.
Thanks, Nona. It's a great privilege to be part of the MPN Voice family. I think we go back now almost 10 years. So thank you for having me as well today to speak about interferon.
Well, let's start then. And my first question is treatment with interferon. What is interferon and how effective is it with MPNs?
So interferons, they basically are naturally occurring proteins produced by our immune system, which helps fight viruses, bacteria, and cancer. It was discovered almost 50 years ago. And essentially, the interferon we use is a man-made copy of the naturally occurring interferon used to treat MPN and other conditions as well.
Okay. So when would you use interferon with MPNs? When particularly would you use it?
So in the case of ET and PV, we use it when treatment is indicated, mainly in patients who are less than 60 years of age. We do use it in patients who are over 60, but we have to select our patients. It is a very safe and effective option in pregnancy or in patients who are trying to conceive, both male and female. And it's used as second line in patients who are intolerant or having a poor response to hydroxycarbamide or the other drugs we use in these conditions.
And are there different kinds of interferon?
Yes, there are many different kinds of interferon. I think I'll just simplify it. I think we have the shorter acting ones and the longer acting ones. The shorter acting ones are used 3 times a week, and the longer acting ones are used roughly once a week or longer. The preference generally is to use the longer acting interferons because the side effect profile of these drugs are the longer acting ones are better. Although these have not been proven in trials, but in clinical practice, we see that they're tolerated much better.
And do all patients tolerate interferon? Is it something that you have problems with, or how does it work?
So the agent I use, Nona, is called Pegasus, which is a longer acting interferon, which is a pegylated form, and it's an interferon alpha 2A. I usually start at a small dose at 45 micrograms weekly, and then I titrate the dosing if needed, depending on response. Now, starting at a smaller dose does help reduce the severity of flu-like illness and tiredness, and this is the most common problem encountered in almost 50% of the patients. But I see that this usually wears off after a few months into treatment, and most patients do find means to cope with it. Now, the other thing I would like to mention is that once I have achieved a response and this is sustained, I try to reduce the dose and frequency of the drugs of interferon, and most patients, in my opinion, do not require a weekly dose. So what happens is that this does improve patients' well-being on treatment. It reduces the discontinuation rate and also the toxicities.
Thank you. And if interferon doesn't work, what next?
So I think you're kind of talking about what the future lies with ET and PV. So the rate of progress in ET and PV and other MPNs as a whole is very exciting, and Nona, I think we could be here all day discussing it. But I think the best thing is that I just mentioned a couple of important developments in ET and PV. Firstly, I think we have improved our understanding and our classification of these conditions better with the advent of molecular mutation profiling through next generation sequencing. Now, as a result of this, the way we stratify these conditions is just being continuously improved. And this helps physicians quite a bit because we can individualize treatment options according to their need. I think in the next decade that this information will help the development of new medications, which would hopefully change the natural history of these conditions. Secondly, there are several trials that are being conducted in ET and PV, and recently we have had some positive results on 2 drugs in PV. One is the next generation interferon called ropeg interferon, and more recently a JAK2 inhibitor called ruxolitinib. Now, both these drugs have shown high rates of complete hematological response and molecular response. But more importantly, it has also demonstrated for the first time that ruxolitinib molecular response is linked to survival. Now, the unfortunate news here is that it's yet to be available in the United Kingdom. Now, I understand that the rate of these new drug developments may seem slow, but a lot of them are already in trials now, and many are so close to reporting. So we'll see a lot of options and changes becoming available to us in the next 5 years or so. Thank you.
This is really exciting news. I mean, when we think back to the early days of recognitions of MPNs, thank you so much, Arvind. This has been a really helpful chat about interferon, and I'm sure will give a lot of people a lot of hope for the future too, with the medications coming down the line.
Yes, yes, of course. And I think we have to stay positive and remain positive in the current climate, because the new drug development rates is much, much faster than it was before. So these are exciting times.
It is. And thank you again. And we look forward to seeing you in Llandudno this year on September the 22nd.
Of course, of course. I'll see you then.
Okay, thank you.
Thanks, Nona.